Hello, I'm Brian Chinnock from UCSF Fresno Medical Education Program. We're discussing vaginal self-sampling and gonorrhea and chlamydia diagnosis. Now, the standard of care in the ED for gonorrhea and chlamydia is diagnosis with a nucleic acid amplification test, or NAAT. Standard NAATs are not ideal for an ED setting as they take 1 to 2 days for a result, and the provider must decide on empiric treatment on the basis of history and physical exam, which is extremely unreliable. This results in both under and over-treatment of gonorrhea and chlamydia in female patients, with under-treatment rates of 32 to 53% and over-treatment rates of 40 to 88% noted in the ED literature. Now, development of a highly accurate rapid NAAT giving results in 90 minutes has opened the possibility of confirmatory diagnostic testing on the index ED visit. However, this still relies on provider-performed endocervical sampling, which in a busy and impacted ED may add significant time to have a room or provider available to do the pelvic exam. This may still result in undertreatment as the patient ends up leaving before the room is ready or before the exam results, or overtreatment as the provider realizes that this is going to take too long and they're worried about the patient leaving and they go ahead and treat everyone empirically anyway. Another option then for earlier collection, without the need to wait for pelvic exam, is patient-collected vaginal self-sampling. Now, self-sampling has been shown to have equivalent sensitivity to provider-performed endocervical sampling for the detection of gonorrhea and chlamydia in gynecology and STD clinics, but has not been examined in the ED setting. The objective of this study then was to determine if sensitivity of self-sampling was non-inferior to provider-performed sampling in the diagnosis of gonorrhea and chlamydia. This is a single institution, prospective observational cohort study with a convenient sample of adult female patients who were enrolled if the provider thought that gonorrhea and chlamydia testing was needed. Patients were excluded if consent could not be provided in English or Spanish, or if the provider felt that the patient lacked capacity to follow self-sampling instructions. A simple one-page form was given to the patient and brief instructions for how to collect a self-sample. Gonorrhea and chlamydia testing was performed with a rapid NAAT with a 90-minute turnaround time. Patients had both self-sampling and provider-performed sampling during the ED visit. Now, the self-sampling was compared with provider-performed sampling as the gold standard. The primary outcome measure was non-inferiority of the self-sampling using a sensitivity of 90%, as has been previously referenced for point-of-care testing. Now, secondary outcome measures included the concordance of self-sampling with provider-performed sampling and the patient acceptability of self-sampling. There were 470 patients enrolled, 15% of whom were positive for gonorrhea or chlamydia. 33% had gonorrhea alone, 52% with chlamydia alone, and 15% with co-infection. Self-sampling was found to have a sensitivity of 97% with a lower 95% confidence interval of 91%, which was above the pre-specified 90% for non-inferiority. The concordance rate was high at 99%. Now, there were 160 patients who declined enrollment, with most of these patients citing a reason of being in too much pain to do the consent process. Of the enrolled patients, 98% found self-sampling acceptable, 79% felt confident in doing it correctly, and 81% preferred self-sampling to provider-performed sampling. Now, limitations. Now, setting this up as a non-inferiority design may have not be the best design for this study, as previous studies have not established provider-performed sampling as a true performance gold standard by which to judge self-sampling. It is, however, the gold standard of how gonorrhea chlamydia diagnosis is performed in the ED. Despite this, the lower range of the 95% confidence interval still was above 90%, and it also demonstrated a high degree of concordance with provider cervical sampling. Also, when looking at overall numbers of gonorrhea and chlamydia diagnoses that were missed by each sampling technique, each had 1 miss for gonorrhea, and self-sampling had only 2 misses for chlamydia, while the provider sampling had 5 misses. Inclusion self-sampling using a rapid NAT has a non-inferior sensitivity compared to provider-performed sampling in the ED setting. It also has a high rate of concordance with provider-performed sampling and high patient acceptability. Self-sampling is a good option, first of all, in patients in whom a pelvic exam is refused or cannot be done. In addition, self-sampling would allow for earlier collection of samples for gonorrhea chlamydia testing when getting a room or provider for a pelvic is difficult. To this end, we have a future study examining the implementation of self-sampling gonorrhea and chlamydia testing early in a provider at triage model to determine its effects on decreasing length of stay and under and over treatment. Thank you very much.